everybody. So I got these pants a couple weeks ago. And you know, the last several years, the pants seem to be getting tighter and tighter, even on men. So, you know, this is a tailored fit, so I got them. Whew, they're pretty tailored. So, if it appears that I'm a little uncomfortable on the stage, it's because I am. I keep like pulling down things here. All right. So my name is Tony Chicotel. It's actually, I mean, if my great-grandfather had not come through Ellis Island, it would probably still be a Chicotel. We lost the vowel over the ocean. And it changed spelling. I was in Italy 2 years ago, and getting on the plane in Rome, coming back to the United States, the ticket agent took my boarding pass and said, Signor Chicotelli. And I thought, what a great way to end my Italy trip. Someone saying my name perfectly, and it's not spelled, I mean, it says Chicotel, but she knew. So, yeah, I'm really happy to be here. I'm super excited that there's a full room to talk about things, and Ruth was talking about spending on research, which is absolutely fundamental, and it seems like at least once a week in the New York Times or the Wall Street Journal, I read a story about some development in Alzheimer's research, and it's a pretty exciting time, but I think unfortunately it's still going to be several years before we start having you know, testing a vaccine and things like that. So what Tina and I are going to talk about today is sort of the old-fashioned approach to dementia care, which is basically love and human kindness. On that note, these are my boys. This started, so Reggie and Cal, this is their Halloween. We don't dress them like this normally. This is their Halloween costume. They were Buddhist monks. About a year and a half ago, I was in Sacramento doing a presentation, and you know, my partner was pregnant, and so I put a sonogram picture up, because I was so excited. Hey, look, I'm having twins. Oh my God, what am I going to do? So it's sort of become a tradition now. I start off with a picture of Cal and Reggie, and you can see them growing. They're doing great. Okay, so here's what I want to impart with you today in my little bit of time I've got. To just stop thinking about dementia in medical terms and to start thinking about it in human quality of life terms. And I know that there's a lot of overlap between the two. But in my world, the world of long-term care, especially professional long-term care, I've seen a lot of problems that stem from what I think is the over-medicalization of the disease and not really focusing on the human touch in treatment. So we've got a situation where now in nursing homes, and there's an enormous population of people with dementia in nursing homes, 60% of nursing home residents receive a psychotropic drug of some kind, and I'll talk a little bit more about what kind of drugs I'm talking about, but probably for the people with dementia, the number is more like 80 to 90%. So a very high usage rate. And I'm going to talk about a least medicating approach, and Tina is going to reinforce the principles and actually go a lot farther in detail. I also want to mention, before I get into it too much farther, this is an international issue. You know, we talk about American policy and California's law. I'll talk a little bit about California law. But it's definitely an international problem, and the Alzheimer's Association equivalents in other countries have been leaders on this notion of reducing the misuse of antipsychotic drugs or ending the misuse of antipsychotic drugs, and actually have been remarkably successful, especially in England with the Alzheimer's Society has been a national leader in this movement. In Australia, I recently heard that the president of they call it the Alzheimer's Australia, was named the Australian of the Year for her work fighting against the misuse of antipsychotics, and she said, this is her quote, chemical restraints with antipsychotics is an unacceptable practice, increasing risk of cognitive impairment, strokes, and falls. That was her quote, one of her quotes in her acceptance speech for Australian of the Year. So this is going on in a lot of different places. This is an ad from the, I think the early 1970s. I thought you would find it interesting. The images of the, what they called back then, the senile elderly man, wielding his cane, getting ready to hit somebody over the head if they don't leave him alone. And the, I guess the very stressed out caregiver, probably daughter here, saying, "Doctor, what can you do for Pop?" Thorazine. And then, you know, with Thorazine, patients become calm, agreeable, and sociable. They begin to eat and sleep better, often gain weight, and improve physically. So, geez, even if you don't have an elderly, maybe you want to take Thorazine. That's kind of what we're up against. And this is the early 70s, and we have a culture, especially in America, where for every problem we expect that there's a pill. Anything related to cognitive issues or physical issues, we expect there to be a pill. And, you know, here we're looking for the pill to prevent the guy from hitting you in the head with a cane.
Yeah.
My personal story on this is, so it was mentioned in my biography, I lived for a brief while in Las Vegas, and I went to mental health facilities, basically fought to get people out of there because they all want to be out of there. So I was their lawyer representing them in civil commitment hearings, and the district attorney would argue that they needed to stay and get treatment. So I was really interested in institutional care, and then I went to San Diego and started representing just seniors. And in institutional care for seniors, it's usually a nursing home type scenario. So I spent a lot of time in nursing homes. And when I would first go, I would, and if you've ever been to more than one or two nursing homes, you've probably seen it. People in the hallways, residents in the hallways, in wheelchairs, sometimes bound to the wheelchairs, and really out of it, or maybe in their bedrooms, just totally out of it, in the middle of the day, slumped over, sleeping with their mouths open, drooling, just totally disengaged from the world. And I would go and I'd say, "Oh boy, you know, it's so sad they have this disease and they're really, you know, tired all the time and they're disengaged." And then as I started doing more and more rights-related work in nursing homes and learning from people like Tena, I figured it out, that it wasn't the disease that was causing this disengagement, it was the treatment that they were getting for the disease. And that really turned things around for me when I started to realize that this wasn't the natural course of dementia or Alzheimer's. It was the overuse of the pills and the reliance on the pills to keep people quiet while other care is being provided in the facility. Very scary kind of notion to me. So this is my slide, an increasingly arcane reference to the television show Different Strokes. Former gubernatorial candidate Gary Coleman used to say to his brother, "What you talking about, Willis?" So what am I talking about, Willis? I'm talking about psychotropic drugs. And in the nursing home regulations, it breaks it down into 4 classifications. And my order is very deliberate here. I think about it as a baseball lineup. The number one, your leadoff hitter, number one is somebody who gets on base a lot. And for me, that's the antidepressants because they get used a lot. It's probably the most heavily used psychotropic drug for people with dementias, and it's the most used psychotropic drug in nursing homes by far. So they get on base a lot, the antidepressants. Then you've got the hypnotics, the number 2 hitter. You want them to be pretty versatile. They can lay down a bunt, they can hit the ball the other way, move the runner up. Not a glorified role, but very useful, and that's your hypnotics, your sleeping pills. Then the number 3 batter, in some lineups this is usually your best batter, the most effective, quote, treatment, and that would be the anti-anxieties. And then the cleanup hitter, the big bopper, the Babe Ruth of psychotropic drugs, antipsychotics, the ones who really sort of knock people out and disengage them. The use for psychotropic drugs, almost all of the, I think, drugs that are in use were initially being used for some other thing. And there was this sort of happy discovery that they made people seem more calm, less agitated, so they began, or lift their spirits. And so they began to be used to treat mental illness. And the FDA has approved their use to treat mental illness. They have not approved the drugs for the use of convenience of caregivers, for controlling behavior, those kinds of things. This is really directly from Tena. Tena will go into more detail about this. Why do we give these drugs to people with dementia? Because we don't know what else to do. And there's really sort of two approaches to that. One is you can sort of see the frustrated caregiver, I don't know what else to do. And then the other side of that is, where are the alternatives? We need more focus on the alternatives. People go, when they're having issues with somebody with dementia, a lot of times they call the doctor, especially in nursing homes, they call the doctor. And what's a doctor going to do? The one thing that a doctor has a monopoly over, the only thing that a doctor has a monopoly over, especially in this age of internet information, where you can get diagnosis information, treatment information pretty much with one Google search, the one monopoly doctors retain is the prescription. I listened to a webinar on dementia care. It was done by a pharmacist, a nurse, and a doctor last week for the American Healthcare Association. A free webinar. It was really nice. At the end, there was a question that was posed to the presenters, and it asked, what do you do with these extremist advocates who argue that antipsychotics should never be used? And the response was what you would expect is, well, that's an extreme position, and there's a place for these. I've never advocated for the complete elimination of antipsychotics as a potential remedy for behavioral challenges associated with dementia. So don't get me wrong, I think that there is a place. It's just, I feel that my role is to kind of put some doubt into the minds of care providers that maybe that this isn't the best way, that there are alternatives that should be explored and tried first. And if all else fails, then you can maybe start to think about pharmacologic alternatives. So with antipsychotics, there's some really nasty side effects out there, including death. And in 2004, 2005, the Food and Drug Administration required that all antipsychotics be labeled with a black box warning label that says, if you are elderly with dementia, these drugs can double your risk of death, more or less. And there's plenty of studies that show the adverse outcomes, and ironically, one of the adverse outcomes is it can make cognition actually diminish. So you get worse, you get more agitated on these drugs for some people. So some pretty nasty stuff. One of the leading studies on this is called the DART, D-A-R-T, which I can't remember what that stands for, -AD, Alzheimer's disease. A really engaged, thorough study of 3 years of results of people with dementia who are antipsychotics, about half of whom were changed onto a placebo pill, and the other half were maintained on antipsychotics. At the end of year 1, 70 of the people on the antipsychotics were still alive. 77 out of every 100 of the people who were on the placebo were still alive. So a little bit of a difference there. 7 out of 100 may be preventable deaths, or deaths that could be potentially attributed to the use of the antipsychotic. But then it gets worse. Year 2, 46 out of 100 on the antipsychotic were still alive. 71 on the placebo still alive. At the end of year 3, we have the doubling. 30 people out of 100 still alive on the antipsychotic, 59 not on the placebo still alive. So as time goes on, the effects get worse and worse. And I've seen some arguments sort of defending the use of antipsychotics as a treatment here that talk about only you can only expect adverse effects on something like 9 out of 25 and maybe a death 1 out of 25. That's in like a 6-week, 8-week time period. So as you extend, and a lot of the use that I see is chronic for years and years, and you'll see increased death. I'm just going to throw this concept out here. I don't have enough time to really get into it, but there is a growing literature that's expressing the belief that maybe psychotropic drugs aren't that good even for mental illness. The reason being, we have more and more drugs, more and more pharmacologic interventions to give to people with mental illness, but the incidence of mental illness continues to grow and get worse. So again, why are we using antipsychotics and psychotropics for people with dementia? There's a lot of reasons, a ton. Number one, someone looks like they're in distress and we want to help them. And again, culturally, one of the ways that we help people who are in distress is to maybe give them a pill. We don't realize the dangers of the drugs in the long term. Caregivers are stressed out. They're looking for anything that will help. And this seems to work in the short term, so heck, it must be okay, at least for now. Enormous marketing efforts. That Thorazine ad, that type of marketing effort continues. The pharmaceutical industry has displaced the defense industry as the biggest defrauder of the U.S. government because of all of the mismarketing of antipsychotics in particular as a, quote, treatment for dementia. Pharmaceutical companies aren't supposed to be making marketing efforts with antipsychotics as a treatment for dementia, but they've done it for years and years, and now they're paying the federal government penalties for their mismarketing. And again, the doctors, they hold the one hammer of the prescription, so a lot of times things start to look like nails that might otherwise not. So this, to me, is the real root of the problem. We've sort of medicalized people's behavior, and let's think about it as I would think about it now, with children. If you see a baby who's crying, do I call that a symptom, a psychological and behavioral symptom of being a baby? The way we say BPSD, behavioral psychological symptoms of dementia, BPSD, I see it all the time in the research literature. BPSD, that behavior and psychological symptoms of being a human being who's not too happy about things. That's the way I see my babies when they're crying. They're at dinner time and I put nothing but vegetables on their tray. Sometimes they cry. And I don't think it's because they're having a behavioral challenge. I think it's because they want to know where their blackberries and blueberries are. And there's the current president of the American Medical Directors Association, a guy by the name of Jonathan Evans. He does a funny sort of workup where he presents a PowerPoint slide that says, here's one of our recent residents, and it's 80-year-old man cries at night and screams and upsetting the roommates and resists care, and what do you think about this guy? And then he shows a picture of his son when he was like 2 years old. And says, let's change the frame a little bit here. With children, you sort of expect it, and you see an unmet need, and your first reaction is to meet the need. Whereas with somebody who's older, you see a disease, and you see a side effect or a symptom. You see a symptom of the disease, and you want to treat the disease as opposed to just making them feel better and meeting their need. Pretty simple concept, right? I mean, I think what happens is, especially among professional caregivers, you see it time and time again, and you're in nursing homes particularly, you're in what looks like a medical institution, and there's people in white coats, and there's doctors at the nurses station, and there's nursing going on all the time, people with IVs and wound vacs and serious medical stuff going on. You start to think of everything through the prism of medical need instead of looking at people as human beings. And even I do that sometimes. It's hard to avoid. So real quickly, the principles of a least medicating approach, because Tena's going to do a much better job with this than I am. To accept behavior as communication rather than as a symptom of a disease. Knowing the the person who's receiving the care is of utmost importance. Why might somebody be wandering? Is it because they were somebody who were very physically vigorous before they came to the facility, and now they're, no one's tending to their physical activity levels, so that they're really just sitting in bed all day? Might that be one reason why they're wandering? We've got people who go into other people's rooms, and then you find out that they were a nurse, and then maybe think they were doing rounds now that they've got dementia. So know who they are, and really, really importantly, don't try to change what you think is their erroneous thought process. Just meet them where they are, and good things usually come from that. Tina talks about this all the time, and I'm sorry to constantly steal your thunder, but I've learned so much from her. People with dementia still feel happy, they still feel sad, they still feel uncomfortable, they feel pain, they feel joy. So when they're acting a particular way, it's usually a result of what they're feeling. So if there's evidence of distress, try to figure out what's causing it. Again, this is not rocket science. A team approach is very helpful. Documentation, when there is a particularly bad behavior problem, document what the circumstances were. The next time it happens, document the circumstances. You start to see patterns, and maybe you can figure out what's really causing this. Again, agitation, prevention is, an ounce of prevention is greater than a pound of cure here. And drugs, as a last resort only. There's lots of other ways to approach problem behavior before you start to really try to control them with a pill. Just a little bit of history here. This is not new. The movement to reduce the reliance on pills to treat dementia is really, really old. I was reading 1975 testimony in Congress about the misuse of psychotropic drugs, including Thorazine, in nursing homes. It was called chemical restraints, kickbacks, and overuse, something like that. And it was 1975, and they were quoting reports that were as old as 1970 about the misuse of the psych drugs in nursing homes. In 1987, federal legislation was passed that partially targeted this problem. The laws are actually pretty good, but things get away from us, and there's sort of an ebb and flow here, and for a while the numbers were getting really, really high again. And then in 2011, there was a federal study that found a lot of misuse. Again, there were more congressional hearings on the matter. And that, oh, there's my alarm. That means I gotta go. Wrap it up, buddy. Which I'll do. But I got started a little late, so I might get So the federal government, the governmental agency that's responsible for overseeing nursing homes, the Center for Medicare and Medicaid Services, CMS, issued a national initiative, or started this national initiative, and Tina and I have been partially involved in this, and they set a lot of goals, but the primary goal is to reduce the number of people in nursing homes who get antipsychotic drugs by 15% by the end of 2012. And in California, we met as a state, and we came up with an even bigger goal of 30% reduction by the end of this June. We didn't make it, the 15%. There's different ways of measuring the numbers. The way I measure it is we did about 5% reduction in the end of 2012. California, depending on how you measure it, is about between 6 and 9%. So we're doing well. I mean, we're talking thousands and thousands of fewer people getting antipsychotics, and part of me wants to jump up and down and go, woo, yay! We're doing it because the numbers were really just, I mean, you can see there's a trend now. There's a curve, and we're going down, and that's really affirming. But it's going to take a lot of work. There's so many facets to this problem. Hospitals, there's a huge reliance on psych drugs in hospitals. For anybody who shows any distress, it's not just people with dementia. The impulse to sedate is really big in hospitals. There's assisted living facilities where we don't have the same kind of laws, and over oversight that we have in nursing homes that we do, or in assisted living that we do in nursing homes. So there's a lot of work there. And for all the people who provide care in the home, the vast majority of people with dementia get care in the home, and the stressed out, harried caregivers, how do we get education to them is a challenge. So it's going to take a while. Just real quick on the laws, this is nursing home law. Person-centered care that Tina talks about all the time, that's required in the federal law, the 1980 stuff that I was mentioning earlier. You can only use antipsychotics if it's necessary to treat, and if you really go through the matrix of what could be happening here, so many times it's not in fact necessary. GDR is called gradual, it stands for gradual dose reduction. That's a requirement in nursing homes. They have to every so often look at the drugs and try to reduce them if they can. And then informed consent, that's a big deal for me. As a lawyer, people should not be given treatment of any kind unless they've consented. And I know for people in a dementia situation who might be cognitively compromised, there's issues with consent. A lot of times that goes to a surrogate. Somebody else steps in and can make those decisions. But a lot of times family members and the patients aren't involved. They're not being told what's really going on. I've heard from so many family members who were told about an antipsychotic was to help the person sleep, which is not informed consent. This is a form from a nursing home. I won't go into too much detail about it, but it basically makes it sound like this drug it's FDA approved for this use, and it's a good thing that will help your loved one. And my question is this really informed consent? There's no real discussion about the risks, about the doubling of the risk of death. And then this is a doctor's order from a nursing home in a lawsuit I was involved in. That I know it's really hard to read, and it's really hard to be doctors writing anyway. Sometimes I think that that's intentional. So people like me can't figure out what the heck's going on. But here it's Risperdal Consta. That's an injectable form of an antipsychotic drug, 25 milligrams every 2 weeks. The reason why, increased episodes of elopement. If you knew this guy's story, this is just, it drives me nuts. This guy was taken from his home to a nursing home. His family was discouraged from visiting for the first 2 weeks or 3 weeks. They were told that if they came and visited, it would be confusing to him and he would want to go home. So this guy had no idea where he was or where his loved ones were. Not talking to them on the phone, not seeing them. He's just in a place full of strangers, so he kept trying to leave. God bless him. That's what I would have done. So they gave him a drug to knock him out and to stop him from wandering or eloping. And within 2 or 3 days, he had a fever of 104. They're reading him his last rites. They're rushing him to the hospital. The guy almost died. Fortunately, he didn't. That is battery. When you touch somebody in that way without their consent and change the way their brain chemistry works, that's battery. That's elder abuse. There's really great alternatives on this non-pharmacologic approach. Dr. Alan Power G. Alan Power is one of the best. He's got a great book. It's called Dementia Beyond Drugs. You can get it off of Amazon for like $12. Fantastic book, full of the person-centered approach principles. My organization, we're known primarily for our website, canner.org. We have a ton of information for people about long-term care issues, and we've sort of gotten more diverse over the years. Financial elder abuse, Medi-Cal, qualifying for Medi-Cal, avoiding estate recovery, those issues, and then the day-to-day issues of life in a long-term care institution like assisted living or nursing home. We have a campaign dedicated to the ending the misuse of psychotropic drugs in nursing homes. That's a capture from our webpage, and we have a consumer guide called Toxic Medicine. You can download it for free. It's pretty good, I think. This is my favorite picture in the whole world. They did not take a nap that day. And they sort of got delirious. And talk about dementia and delirium. And we went on a walk and we came home and they were just so rowdy. And this is before they could really stand up or even really sit up. But they were like tackling one another. And I sat them in the chair and we busted up the camera and they were just so happy. It was a really cool, magical day. I have a lot of magical days with Cal and Reggie, trust me. But anyway, I'll give the floor to Tina, and thank you very much for your attention. Appreciate it.
So if you have not buckled your seatbelt, I want you to do so now. Put your chairs in your upright and locked position because we're going to move like crazy. So thank you so much. I'm Tina Alonzo. I'm from Phoenix, Arizona. I want to especially thank you because you have welcomed me to your state by turning up the temperature a little bit, so I feel perfectly at home. I also just wanted to quickly tell you a couple of things about me. I know you heard my bio and all that stuff, and it really doesn't matter. I just want you to know that I have been a care partner for 4 members of my family with dementia, and I also am a professional care partner for people who are experiencing the disease. So I do dementia all the time, every day, all the time. So today, what do we want to do? We want to learn about what to expect when people have mild, moderate, or advanced dementia. Now I know many of you have probably sat through lots of training sessions where you learn about the disease. But we want to take a little different spin on that. And we want to look at what can we expect. What do we know is consistent across people who have trouble thinking? We want to look at things that will promote comfort, and I'm going to make a good case for why that is important. And we're going to also look at what are some of the positive outcomes that will result from helping create comfort for people who have dementia. Now, you know, we often talk about this disease in terms of being a chronic experience. And for many people, maybe for many years it is. We can look at the progression of dementia from 2 to 20 years. But we know that on average, from diagnosis to death, people live about 6 years. We also know that when we look at this illness, it could be described in many different ways, and certainly different for different kinds of dementia. But we're going to talk about it kind of overall. We're going to lump things together, basically in the interest of time. And we're going to talk about it in terms of a beginning, a middle, and an end. And of course, all illnesses, whether we can recover from them or not, have a beginning, a middle, and an end. So when we look at people who have mild dementia, maybe they're just diagnosed or even before they're diagnosed, we would expect to see that these folks have issues remembering things. They will repeat themselves, often talking about favorite stories, or maybe that they have something that's coming up. And within a period of about 10 minutes, they may repeat that a couple of different times. We know that these are folks who often have difficulty with managing their finances. And so they pay their bills all their life, but they forget to pay them, or maybe they pay them twice. They have difficulty with their checkbook. As a clinician, often what I will do when I'm working with somebody is ask them, so, how's it going with managing your checkbook? And they often look at me with this look of horror, like, how does she know? The truth is, the reason I know is that consistently people really do have difficulty with it. We know that these are folks who sometimes get depressed. And it kind of makes sense. And as a result of their depression, they may opt out of the bridge club. Or they may decide that they don't really want to go and do this, that, or the other thing that's been a huge interest of theirs. And you know why? Because they know something is wrong and they don't want anyone else to know. And of course, it makes sense that you might be a little bit depressed in the mild phase, after all, because we've got all of this discombobulation going on in your brain. And every day, there are new brain cells that don't work quite as well as they used to. And so it's important to know that our brain chemistry will probably be a skosh unbalanced. We know that after a time frame, different for every single person who has the disease, they move from the mild to the moderate phase. And when they move into the moderate phase, it's important to know that they really shouldn't be alone, that they will do things that are potentially harmful to them. So for instance, they're going to put something in the microwave that they shouldn't put it on and put it on for 10 minutes. They're going to leave the teapot on the stove and burn it up. They might sit in the chair and not go to the restroom for 3 hours if they're alone because they can't remember where it they forget to eat, they start to have difficulty with a lot of frustration. And Tony mentioned a minute ago that our emotions are intact, so our feelings are still there. But the ability to reason ourselves out of some of the upset that we might feel as a result of things going on, we've lost that ability in the mild phase. And so when we get upset, guess what happens? We stay upset. And in the moderate phase, we see that particularly happening to most folks. They did a fabulous story a couple of years ago, and I'll share it with you very quickly. But they looked at like 1,000 people who had dementia. And most of these folks had the late, mild, early moderate dementia. And what they did is they broke them into 2 groups. And about 500 of them went and saw a very happy movie. Comedy, people loved it, great thing. The other half saw a sad movie. Very sad, very dark. And then they talked to them about their feelings afterwards. Now, most people forgot that they had seen the movie pretty quickly. We would expect, talking about what to expect, we would expect that. But you know what they were able to do? They could report and remember feeling happy if they saw the comedy and sad if they saw the sad movie. What that tells us is that the ability to feel is still very much intact for them. So that we see in the moderate phase that people can become really upset. And unless we help them become less upset, then they're going to stay stuck in that. And I think those of us who are care partners may see that often. Boy, so-and-so had a really bad day, and it was really bad all day long. Because it kind of went south, and then we didn't realize that we needed to change it and help them get out of that because they can't do it themselves. These are the folks who often are most at risk for the use of antipsychotic medications because they're the ones who demonstrate to us lots of dementia-related behavior. And these are the folks who misunderstand what we're trying to do, and much of the time we need to help them with a lot of things associated with their daily experience. To help them dress and groom themselves and help them with eating and all different kinds of things. So they're the ones who are probably the most physically fit and the most at risk for showing us some dementia-related behavior. These are folks who have a great deal of trouble communicating. So we would expect that they have difficulty really expressing themselves. But what we don't understand is that often they don't understand what we're saying to them either. And it's confusing to us as care partners, as professional caregivers. It's really confusing because they have this social facade. So we say to them, Miss Jones, would you like to use the restroom? And she goes, no. But you know she's got to do it because she's kind of got the pea shakes. And so it's really confusing. What do they want? How can we help them? Even though they may not be understanding what it is we're telling them or asking them verbally. After a time, we know that the person moves from the more moderate phase into the advanced. And this also includes the last 6 months of life in which the disease is terminal. You know, often when we're talking with family caregivers in particular, it's tough saying, Alzheimer's disease, dementia, is a terminal condition. But I want to offer to you as a person who has made the journey with now 4 members of my family, there's power in knowing that this disease will take a person's life. And the power is, let's do for them, let's help them enjoy every single day. Because we know they're numbered from the very beginning when we get the diagnosis. We know there will be an end related to this illness. But in the advanced stage, the person really is dependent on us for most of their care needs. They have very difficult time communicating, maybe 7 words or less that make sense. They stop walking, and they start to have issues with swallowing, and often they have recurrent infections, which may be the reason that their life is ended. that very quick, this is what you should expect from dementia, is where we generally leave off. But I want you to know that what we should be looking at is how resilient the human brain is. What a magnificent organ the human brain is. Even though Alzheimer's disease and other dementias take away our ability to think, it does not take away our ability to feel. And it doesn't take away our ability to communicate. So, for instance, Tony was just talking about how, when the babies their needs are not met, what do? They go, "Rah!" And what does he and his partner do? They go over and they take care of them. We are no less different. Whoops. Help. I'm going to keep talking. We are no less different. There you go. Fixed it. Yay. We are no less different. We all communicate through our behavior. But all of us are still able to verbalize as well. So we have the combination of being able to articulate ourselves verbally, along with whatever kind of behavior which supports what it is we think and feel. So for instance, if our partner makes us angry, and we tell them about it, about how difficult or negative it was, whatever it is that they did, and they say, "Well, sorry," we don't take what they say at face value, right? We saw how they crossed their arms. We heard the intonation in their voice. We're always behaving and communicating through our behavior. The person with dementia is not different. We know that if we want to create a positive experience or change the way somebody feels when they have dementia, we know that we can do that through the five senses, in that they're intact. The taste of chocolate makes as much sense to the person with advanced dementia as the person who is not diagnosed. And in that, whatever thing that we are doing that creates a sense of connection or peace, contentment for that person, using their five senses, we can use that. The brain remains an expert on whether or not it is comfortable, whether or not it needs to try and run away or defend itself if something is potentially creating a risk. All of those things are intact. Our resilient brain is intact, and it remains intact until we draw our last breath. Now, what does that mean for the person who has advanced dementia? It means they're an expert on whether things are suiting them or not. What's interesting to note is that for many of us, we don't know that. We think that we have to do for them, and they don't know when they're comfortable. But they do. They do. And if we use that, we can ultimately create for people who have trouble thinking the best experience possible. So this is a message of hope this morning. The answer to creating a better quality of life, a better experience for people with dementia, is by looking at comfort. And I love this definition, and I love the words that describe comfort. To give strength to. Any of us who have family members with the disease, or any of us who are professional caregivers, doesn't it make sense? The people who have dementia, we want to ease their grief or trouble. These are powerful words. We want to console them. We want to soothe them. We want to reassure them in a world in which they feel like a stranger in a strange land. We want to give them strength because we know how difficult this disease is. And often, if we're able to do these things, no matter whether we're families or we're professionals, we feel good too. It gives us strength and consoles us too. So I didn't want to not share a clinical definition of comfort. You know, so often when we think about comfort, we're thinking about end of life, aren't we? We say comfort care, and it means that it's at the end of life. What I want to say to you, yes, it does apply at the end of life, but it should not be reserved for the end of life. And I'll tell you why in just a second, but I just wanted to show you this very clinical definition of comfort. And it looks at interventions that are holistic, so all different kinds of things, both medical and social and emotional and spiritual are all important. Focuses on dignity, focuses on the family, focuses on respect for both. Looks at what is intact for the person, not what is gone. And creates the best environment possible. Now in this definition, you will see that there is no mention of end of life. Because what I'm proposing to you today is that we move this way upstream. And here's the reason why. How do we prefer to live as humans? Do we go and seek out everything that makes us uncomfortable? No, we don't. Now, if I do a really good job at the presentation this morning, you all are happy with me, I am probably going to go celebrate with something the lovely Sacramento has to offer. However, if I fall on my face and I do really poorly, I'm going to go and drown my sorrows in something wonderful that Sacramento has to offer. Because that's how we are. That's how we are. We create for ourselves a sense of what makes us comfortable, and that's what we do. The difference for people with dementia, they want the same thing. They just can't do it for themselves. So we have to. Now, if we're looking at home or community-based care and service, these things still apply. Because sometimes we as family members, and my family has been no exception, get really focused on how medicalized dementia care is. I know how to fix it now. So if we look at what goes on, and it's a disease, so it makes sense. We're going to think about it in terms of what is medical. We're looking at this as an illness. We would love to cure it. It'd be fabulous if we could, but we can't just yet. Hope is pretty soon we'll be able to say, look, you know, Tena Alonzo's doing something else. We know often in that medical realm that care and service is driven by the provider, the insurance company, the physician, the advanced practice nurse. We know that the emphasis, especially if you're in an organization and your loved one is living in an assisted living or a nursing home, that it's about when can the staff do this or that. We know that in the medical field that people are really not supposed to get close. That works in the hospital when you're there 3 days on average and you're going home. But when you're in an organization where people live, you're going to be there a long time. It doesn't make sense that you would know who the person is, what is uniquely special about them, so that you can create things around that ultimately would give them comfort and contentment. And also, and my husband was in the hospital last week, I can tell you this, just try to go talk to the doctor. I was probably seen as a family member who was a problem. Just because I wanted to talk to the doctor, it wasn't even negative, I just wanted to talk to the doctor. Okay. So sometimes the medical model of care and service gets in the way of comfort. And what I want to propose for you this morning is something that makes a lot of sense to many of us professionals across the country. And that is, rather than focusing, say, on a cure, we want to look at what is comfort in body, mind, and spirit, and that connection. What if care and service is driven by the person? Very consistent with CMS, and really very consistent with what the person with dementia wants, okay? If I have trouble thinking, I want you to listen to me. I don't want you to disregard what it is I'm trying to communicate, even if I can't do it verbally. And if you do disregard it, what am I going to do to you? That's what I'm going to do, probably because I'm frustrated, or I don't understand what it is that you're trying to accomplish with me, even if it's really important for you to accomplish it. I need to have things done on my own time. I need to sleep when my body says I'm done, and wake when my body says I'm refreshed. I need to have a bath in a way that makes sense to me, not to you. Because otherwise, I'm never going to be able to accept it. My brain's doing the very best it can just to do what I'm currently doing. And so unfortunately, for us as family and professional caregivers, we have to change. We have to change because the person can't. And of course, in a holistic model or a comfort-focused model, we need to know who the person is, what really is important to them, not just their medical condition. And we need to embrace fully their support system. The person with dementia, their support system knows so many things that we as professionals will never know, that we ultimately can use to create the best sense of this comfort in body, mind, and spirit. So what does it look like? And of course, in my preparation for today, I was trying to bridge kind of the fence between families doing care at home and organizations. And so, because dementia does not know licensure, and it doesn't know when the person is at home, these are things that will apply in both places. But the most important thing about a comfort culture is really understanding what to expect from the disease. And we're going to talk in just a couple of minutes about some additional things we should be thinking about. Because so often we're unrealistic in what the person really can do, and it sets us as care partners up for failure. We need to look at the policy and practice if we're in an organization where comfort becomes the goal of everything we do. Now, it doesn't mean that we're not helping people get comfortable and clean, but we're doing it in a way in which the person feels at peace with it, not in a confrontational way. We want to look at all the systems that impact people with dementia. And I don't know about you all, but at the Beatitudes campus where I work, about 90% of the people in healthcare have dementia, even though they do not reside in our dementia neighborhood. And in our assisted living, about 85% of the people have trouble thinking and have dementia. And so it's a population that is really impacted widely by the fact that they have trouble thinking. And systems often are not really tailored to them. They're just generic. And that might be okay if our population was very small in terms of the folks who have trouble thinking, but we know it's really rather large most of the time. So how do we define a comfortable culture? Individualized routines. It's kind of a toughie, this first one. The people need to sleep, and they need to wake according to what their body says. Now that means that we cannot get them up at 5 o'clock in the morning for 7 o'clock breakfast, which is what we did at the Beatitudes for a while before we got some sense knocked into us. That they need to eat when they want to eat, what they want to eat. Now I know there may be folks out there who not only do they have Alzheimer's disease, but they're diabetics. The American Dietetic Association beginning in 2004, and they just updated the paper last year, support liberalizing diets of people who live in long-term care and nursing home associations, or organizations. What does that mean? Give people what they want to eat. There is no benefit to them. And of course, many of those things that we learned as we were kids, we're trying to sustain a body for 80 years, right? So it makes sense. 4 food groups, now they're talking about 5, but the major food groups, all things in balance. For the person who has dementia, it doesn't make sense. Give them what they want to eat, even if it's lemon pie instead of meat and potatoes. We want to use a soft approach. Now, this is especially challenging sometimes when we're looking at things in terms of the medical realm. And we want to just soften up everything that we do. And it's not that we're not professional and that we're not kind and we're not compassionate. We're talking about soft, really toning things down in terms of how we approach people and what we expect of them. We really want to look at pain. There was a lovely study done by Diane Meyer out of Mount Sinai in New York. And what they did is they looked at 1,000 people again who had hip replacement surgery. And they did a retrospective review, which means they looked at the medical records after the person was discharged from the hospital. And this is what they found out about pain. Half of the folks did not have dementia. And these folks received good pain management. Makes sense. They had significant pain related to hip replacement. The other half had dementia. They received 1/3 of the pain management that the folks with dementia received. Now, they did receive medications. We know what they received. They received antipsychotics and anxiolytics. Is their pain different? No. Remember our resilient brain. Our ability to feel pain is there, even though our ability to articulate it may not be. And what happened for this group, unfortunately, is because they were not able to communicate their pain verbally, they were not supported as they should have been, as their counterparts were. And also in a comfort culture, we're just looking for anything that might create discomfort, and we try to fix it. What's important here? Families are essential. They know the person best. They're able to tell us things that may have great meaning to this individual, like the fact that they were a night watchman and they're up all night. So they're not going to lay down. They're not going to be able to go to bed until maybe 6 in the morning. As Tony said earlier, communication and behavior are equal. It's legit. We're always communicating with our behavior. I'm telling you right now that I am an Italian because I am talking with my hands. And my mother always says that if I were had my hands cut off or if they were tied behind my back, I wouldn't be able to talk. We want to look at reviewing dining and bathing and how those activities occur, trying to create the very most comfortable time frame, method, approach for each person. We want to make comfort the goal of everything. So there's a great myth, and that is when a person has dementia, they display dementia-related behavior. It's mystical. We don't know why. They just do these things sometimes. There's nothing we can do, but it's a myth. It isn't real. We know often in the moderate and advanced stages, people can resist care. They call out. They don't want to take their medicine. They curse. They do things that they have never done in their life. They may disrobe. They may try to get out of wherever they are. They may ultimately pee in the trash can or take off their clothing. All things that are associated with discomfort. So what do we know about the brain? And what's really cool about this picture is that, you know, when we look at somebody who is impacted by dementia, we can't see inside their head. So on the outside, do they look like they're anybody else? Pretty much. Even in the advanced stages, if they're sitting up comfortable in a chair, you wouldn't necessarily know that they're impaired, right? But if you were to chop my head right down like this and peer in, looking at my brain from this way, you would see this basic representation in my brain. And I don't have a pointer, but if you look down there at the very bottom, you see an area that's called the hippocampus, doesn't really matter, but where it's really shrunk. Okay? Anytime our brain is shrinking, it's generally bad juju. We don't like it. It actually translates to impairment. So for the person here in the moderate phase with the shrunk hippocampus, we know a couple of things. First of all, it is very difficult for them to learn because the gateway to learning begins with our short-term memory. And because short-term memory is housed in the hippocampus, this person, even though they may have multiple repetitions of something, they can't hold on to it. So for instance, if we say, hey, You have a doctor's appointment this afternoon at 1. We cannot expect that they'll remember it. If they come into our organization to live, and we have breakfast every morning at 7:30, we can essentially tell them till the cows come home that breakfast is at 7:30, but they will not be able to remember because their brain won't let them. When they hear us speaking to them, it sounds like a bad cell call. And when we hear a bad cell call, what do we want to do? Get off, right? But that's what we suspect people with dementia are experiencing. Can't regulate their emotions. The part of them that was able to do that is now long gone. So what happens when they get mad? They stay mad. Oops. They stay mad. Often, that fight or flight response, that part that knows when I'm comfortable and when I'm safe and the part that's not, that may be an overdrive because they may be afraid of everything. They may even be paranoid or believe that others are trying to hurt them. And they probably misinterpret many of the things that we are trying to do to help them in negative ways. Now look, between this and this, look at how that brain has deteriorated from the moderate to the advanced stage. This person only lives in the moment, says very few words, has no ability to learn. Every second is a new experience for them. They may even appear withdrawn, and they have difficulty engaging. So I'm going to have to really talk fast. Okay. Now, what are you going to do? Okay. So what I want you to do is help you reframe dementia-related behavior. Given that the people are doing the best that they can, how can we look at it differently? Because we have our full faculties. We can reason. We can consider things that may be outside the realm of the person that we're serving. So this is just a basic resisting care roadmap. And what I want you to do is, especially if you're a professional or family member, is just take this basic philosophy, take it home with you and try it out. So the first thing I want you to do is clearly identify the behavior. And sometimes we get things kind of all jumbled up and there's several behaviors all mixed together. But I want you to identify it. So my grandmother did not like to take a bath. I could clearly articulate that. And then what I want you to do is I want you to say, what is this person communicating to me? What are they trying to tell me through their actions? Give it some good thought. You know, are they in pain? We often see that people, when water is sprayed on them or when they are put into a bath, that they almost cringe. We can see it on their face. Often that's because not only do they have Alzheimer's disease, but they have any number of different kinds of arthritis. So maybe physical pain is there. Maybe it's fear. They're afraid that they're going to be dunked in water or some other thing is going to happen. Or maybe they were doing something else that they were really engaged in and they just see this as a plain bother. And then what we want to do, we want to look at, okay, what can we do to fix it? What is a remedy for this? So if the person has pain, we want to make sure that they have good, solid pain management and that they're receiving medication that makes sense to them. We may have to tell the physician on that next visit, you know, when I put my mom, help her take a shower, she almost cringes and it looks like she hurts. It's a very clear way of communicating that things are not right from a physical standpoint. We may need to reposition that person. We may need to help them rest in bed at that time if pain is not related to anything else or just basic caregiving. We may want them to just go for a walk with us. That might make a difference. What if they're fearful? We want to slow down. And I've got some basics that I want to talk to you in just a second. We're going to close out with that. We're going to use a softer approach, and we're going to look at what that really entails. If they just don't want to, maybe we need to just not do it right now. Picking our battles is a very big part of being a family care provider. I'm going to skip that one. What if they call out? And many times we see people, especially in the advanced stage of the disease, calling out. And you know, it's really interesting, but if you are able to walk around, you never call out. Often calling out we suspect is what we call motor akathisia, expressed through the ability to verbalize. And if you think about it, if you can't move anymore, if we actually say to you, sit down, sit down, sit down, you're not safe, it makes sense that you will use whatever control you have over your environment to maybe call out. So we hear people say, help me, help me, help me, or ah. We say that it's just dementia, they get like that sometime. But it has a meaning. When people call out, it means something. Again, it could be physical pain, it could be boredom. It could be that they just need to move. And we should be looking at, how do we remedy this? How do we fix it? And so I've included a basic roadmap. You can just put any dementia-related behavior in there, always looking at what is the behavior, what is the person trying to tell me, and what can I do about it? If we do these things, then we are ultimately making the antipsychotic medications, the anxiolytic medications, less likely to be needed. We won't even have to tell the doctor, hey, this is a problem for so-and-so, because we've already ourselves fixed a majority of what may be troubling the person. So here are the things, tried and true, research-based, evidence-focused. Make comfort the goal. How do you help the person get clean in the way that is most comfortable for them? If the person is comfortable, they will not hit you, they will not yell, and they will not curse or seek the exit. They just don't. Don't confront or reason with the person. Their ability to make sense of that is long gone, especially by the time they come to the nursing home or the assisted living. Go slow. I spend a fair amount of time teaching physicians this, and it's very difficult for them to grasp. But whatever makes sense to us, a pace that makes sense to us, it will not benefit the person who has trouble thinking. Think about doing it in twice the time if we want to be successful. Validate the person's beliefs. And by that I mean, if a person believes that they are going to be harmed, the worst thing we can say is, you're okay. Because what is that going to get us? Probably, and they're probably going to say, oh great, I've got the crazy nurse today taking care of me. Let me offer this, and I say this, and all of the folks that I know who serve people with dementia say this. I'd rather say, I validate the person. That sounds really scary, because to them it is. And then I follow that up with a statement, I will keep you safe. Very powerful, makes a difference, and people say, you will? Because that's what they're looking for, someone who understands where they are and can meet them. Please, if you see somebody who has pain, just report it. If you're one of the care providers here or professionals, please look at pain in terms of the person who has dementia. I can almost guarantee you that you will reduce the use of antipsychotics if you start treating pain appropriately. There's a lot of support for this comfort approach, and you can see here the organizations that have supported it. So if you are an organization who's worried about whether or not this is going to work for you, it will, I promise. Those of you who are from an organization or family members who are concerned about the cost of this care, guess what? It saves money. And staff who are engaged in it feel connected to the person and can engage in ways that make a great deal of sense because they're not forcing people through or pushing people through care. You can make sure that yours is the organization where everybody wants to go. So just one or two final thoughts, because I want to make sure you get a break before you go into your sessions. And that is, comfort is essential to the person with dementia and non-negotiable. It really does improve quality of life. People continue to communicate to us whether they are comfortable or not, even though they may have advanced or terminal dementia. We do have the power to create quality of life. We do have the power to reduce the use of antipsychotics and eliminate risk associated with these medications. And ultimately, together, we can create the kind of world in which people with dementia, regardless of how impaired they are in terms of their thinking, can live fully with the disease. Thank you so much for listening to me.